to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community.
Good morning. My name is Lizzie, and I am so glad that you are joining us today, this Saturday morning. So welcome to everyone who has already logged on. If you just want to write in the chat where you are joining us from. So I am currently in London where the sun is shining, which is very nice today. We're going to have a fantastic session and I'll be keeping an eye on the comments that come in. So please get chatting. When you have questions, add them to the chat. So we've got someone from Salford. Where else? Oh, I'm sorry to hear the sun is not shining. The day has only just begun, so a little bit of time, maybe. From Yorkshire, fantastic. How far? Bedfordshire, you're very welcome. Manchester as well, I see. And I hear good things about Somerset, where the sun is shining. We have got an information-filled hour today. Going to be a lot of very good information from someone who's just not a colleague, but also a friend. This is going to be an exciting topic, and I'm sure, especially for the women here, there will be lots and lots of questions, and hopefully there'll be lots of answers today as well. Today's session is going to be fibroids, a doctor's lived experience, and that is going to be from Dr. Itunu Johnson-Sogbetun. She is a GP with a special interest in women's health and the menopause. So I'm sure lots and lots of questions will be coming her way. So she'll be sharing some of her story and giving us lots of details about things that we need to know as women. And also if you're a man, if you know women, it's so important to have all of this information. So please definitely to ask questions, and if you've got anything to share as well, we'll pick those up in the end. And Dr. Itunu, GP, health advocate, woman specialist, I'm handing over to you.
Hi, Dr. Lizzie. It's such a pleasure having this session with you. As you said, we're friends and this is fantastic. And we're both passionate health equity advocates and we work together to support our Black community to improve health outcomes. So it's just such a pleasure to be on this session with you. And thank you, Khan, again for this invitation. So how we're going to do this today is I'm going to just share a few slides. So it's only about 15 slides and talk around setting the landscape for fibroids, and then we will open it up to conversation and questions, because we know a lot of women, a lot of our audience, men and women, will have questions on this topic, because this is a subject that is really emotive and super disproportionately impacts our Black community. So I'm just going to share my slides. So hopefully you can see it, just a thumbs up if you can see it. Thank you. So as Lizzie has said, I'm Dr. Itunu Johnson-Sogbetun. I'm a women's health and menopause GP. So it says over 10 years. It's now actually almost 15 years of experience as a doctor. And in that time period, I've developed a special interest in women's health and the menopause, and I work across the NHS and in the private sector. So I have quite a few qualifications, as you can see, but I'm also a member of quite a few different communities that support women's health more generally. And of course, I'm also a supporter of health advocacy for the Black community, and even more broadly, to improve equity, diversity, and inclusion amongst healthcare professionals, because that impacts our experience as well. So that's me, but also I have a personal insight, because I've actually got fibroids. Now, my fibroids are probably on the milder end of things. However, I have suffered for most of my life with painful and heavy periods. And when I'm talking about pain, I'm talking about from the age of around 10 or 11, when I started my periods, I would be in such agony, I wouldn't be able to go to school. And throughout my secondary school years, up until A levels, I was always missing 2 to 3 days of school for heavy and painful periods. And I would try and manage it with painkillers, but it was sometimes I'd be vomiting. I would be sitting on the toilet and literally flooding. That's how heavy they were. I would wear, like 2 sanitary towels, 2 underwear, and I would still flood right through. So some of you might have a similar experience. So I was lucky, because during my secondary school education, I was, it didn't really impact my ability to get the good grades that I needed, but it could have. And I know that for some people, it has impacted their educational potential. But when I got to university, it became different, because I was in medical school, and it was not okay that I was missing school classes because of my heavy and painful periods. So I was actually, flagged up, and I was sent to see one of the tutors. And thankfully, she was a gynecologist, and she said, why are you missing so much? And I said, it's actually my periods that are really heavy, really painful. I can't come to school to uni when they are happening. And she said, so why don't you have treatment? And I said, I've been to see the GP, and they just said, it's par for the course, or I can go on the pill. And when I spoke to my parents about going on the pill, my mom was like, no, lie, you can't go on the pill. She scared she scared me so much. She was like, this will impact your future fertility. You can't do it. Just bear it. She'll be a woman. This is it. And even though I was a healthcare or a developing healthcare professional, that fear was actually there. So it took this lady exploring my fear and exploring my concerns and explaining to me that there really wasn't any impact on my future fertility. And actually, having the pill could improve my quality of life. So at the time, I decided to go on the mini pill, which is Cerazette, the desogestrel pill, and it was completely life-changing. I was in the lucky category that actually had no periods whilst I was on it, and it was completely life-changing because I was able to enjoy life, complete my studies, really get involved in social life, and it stopped limiting my ability to function. So I do understand the physical, emotional, and mental toll that the symptoms of heavy bleeding and painful periods which can occur with fibroids. I was also anemic, so I would be tired all the time. I also have a thalassemia trait, and of course, this, a lot of our community might carry the sickle cell trait, even if they don't have sickle cell in total, because, it's something that is more common in our community, and that worsened the anemia. So my hemoglobin was always around sort of 9, with an iron that was in its boots, and I would be so tired. So all of this stuff meant that, then I'd have the iron tablets, it caused constipation. It was just not good. So having, something to stop those heavy periods really helped my entire physical health, and I got my energy and strength back as well. So that's part of my story. Let's talk about fibroids. What are fibroids? So I think the word is that they are benign. So that means they're non-cancerous, but it doesn't mean that they're not deleterious. It doesn't mean that they are not impactful. It doesn't mean that they can't be harmful. It just means that they are not cancerous. And they are growths in the womb. So they can be as small as seeds or as big as a watermelon. Or a grapefruit, and so they can grow. So if you look at this diagram, you can see that they can be inside the wall of the womb, they can be outside, they can be in the womb cavity itself. So they can be in the muscle wall, they can be outside the muscle wall, and they can be in the womb cavity itself. And they are made of muscle and connective tissue. And Black women are much more likely to have them, and at younger ages. I think my first fibroid was diagnosed in my early 20s. So that's how, when I first was picked up to have a fibroid. And 80% of Black women will develop fibroids by the age of 50. And that's more than the average with white women, although it's also common in all women. Now, why? What causes it? I would love to have the answer for this, but the truth is we don't know. Now, there's lots of things that we've linked it to, and one thing we do know is that estrogen makes them grow, which is why after menopause they shrink because estrogen drops. But there's lots of other factors. We talk about endocrine disruptors, so things in the environment which we've picked up may impact. So for example, we talk about relaxers, and some people might have heard that may impact their growth. Also, something about vitamin D levels being low might be associated. So there's lots of different things, but nothing clear. We need more research. And they primarily grow through the reproductive years. So as I mentioned, I was very young when my first fibroid was diagnosed. So as I say, it can start from a really young age. Now, the most common impact when women start to struggle with symptoms is around between 30 and 50. And of course, as I've mentioned, it's higher in Black women. So if you've had less children or not carried as many, or has had, you've had fewer pregnancies, you can be at higher risk. Now, if you are overweight, it can be more common. And that's also because some of our fat cells can be converted into to reproductive hormones like estrogen, or sort of estrogen type hormones, and that can impact the growth. And there's again some association with increased red meat. If you eat a healthier diet, it can reduce your risk. But of course, genetics matter. If it runs in your family, then you're more likely to have it. And stress can fuel hormonal imbalance and growth. So it's kind of multifactorial what the risk factors are. And of course, as Black women, we're often under a disproportionately heavy mental load and stress from all sorts of factors. But that includes being primary caregivers. Many of us are looking after the younger generation, the older generation, also supporting our families financially, working full time. Many of us are single mothers in our community. So all of this stress can impact things as well. Now, what are the symptoms? So you have to appreciate that many women have no symptoms of fibroid. So the fibroid is just an incidental finding and it doesn't cause any problems. But for some women, it is diabolical, the symptoms that they have, including heavy periods, painful periods. I've talked about the flooding, and that can be so impactful for women. I mean, I've had so many occasions when I was younger where I would be like, oh my goodness, I'm on the tube and I feel, oh gosh, I may have just, and it's so embarrassing. I've even felt like, oh my God, I just want to just disappear, or it's happened in class. Um, and it can be really difficult to deal with. There's painful periods, and that can be so impactful. You can't get out of bed sometimes. So you're just rolling around, in agony. And then you can get pelvic discomfort. Now, if the fibroid is big enough, it can press on other organs, causing problems with your passing urine. So you might find that you're urinating more frequently. It can impact your bowels. So you might find that you're constipated. You might find in pain during intercourse, a swelling or bloating in the abdomen. So you might actually have like a wound that is so big, it could look like you're almost pregnant. And you're not, it's the fibroid. And it can radiate to the back or to the legs, and it can just cause real discomfort. And then there are kind of the complications. So all of this can then lead to different areas where it impacts. So I've grouped them under several headings. So the first one is obviously the gynecological, which is, we've talked about the heavy bleeding, the pain, the pressure, all of those sorts of symptoms. But then there's the reproductive issues. So it can make it more difficult to have pregnancies, particularly if the fibroid is in the womb cavity, making it difficult for an embryo to implant and grow. And then, of course, if you do have a fibroid during pregnancy, it can outstrip the blood supply and you can get this red degeneration. And so it can make a pregnancy more risky and impact that. And we talked about hematological. So I talked about anemia and iron deficiency, but for some women, it can be so bad they need a blood transfusion because they're so anemic. Some women have such low iron, they collapse from that. It can be really impactful. And a few days ago, we were in Parliament kind of talking about this issue, and one of our senior colleagues talked about her story where the fibroid was so big it was pressing on her blood vessels, and that caused her to have blood clots, and that went into her lungs. So I mean, that's obviously a rare complication, but it happened from her fibroid. So again, we say it's benign, but these are serious health issues that can impact. But let's not even just go to the psychosocial. And those of you who know me know I will always talk about the psychosocial, the mental health impact. So many of us already carry a heavy mental load, but this can add to it and can lead to things like depression, anxiety about going out of the house, anxiety about fertility issues, the stigma, in our community. If you're struggling with fertility, some communities, it can be really, really hard. You might have people talking about you. Some people will struggle, even with their partners and in their relationship. You don't want to tell because you're afraid about, the stigma. And then all the emotional trauma, from dealing with all of this and the complications. And then, of course, very unfortunately, many of our Black women are pushed towards a hysterectomy when that might not be needed. And so we have higher hysterectomy rates compared to white women for the same condition. Um, and then also we have limited access to womb sparing options. Now, again, we will talk about this, that we don't have as good treatment options. But even what we have, Black women seem to be offered less good options for protecting our fertility. And that's impactful as well, because for some people that's important. Now, how are fibroids diagnosed? So, of course, we will always start with taking the story and then examining a woman. And it's really important, I think, to do an examination of the abdomen, of your stomach, and also an internal examination to get a sense of how big the womb is and the impact. But of course, to make that diagnosis, an ultrasound is really important. And GPs can organize these ultrasounds in most areas. But of course, depending on where you live, the access can be limited, and the access, how quick it is to get that ultrasound can be tricky. But the ultrasound can have a look, it can look at the size, it can look at the number, it can look at the location of the fibroids. And all of this is important because it can tell us about whether or not the fibroid is impacting your symptoms or causing complications. Now, for more complex cases, you might need an MRI, but that's not typically used for most people. It's only in complex cases, particularly if you're planning complex surgery, you might want the specialist, and that's usually done by a gynecologist, to gain access to understanding a more detailed where everything is and planning the surgery. Now, a hysteroscopy, and I've had a few of these in my time. In fact, I think on my last count, I've had 7 hysteroscopies for various women's health issues. So I mentioned that I have fibroids, but I actually have other women's health issues, including polycystic ovarian syndrome. I've had endometrial polyps, which are another condition where you have growth from the womb, and I've had abnormal polyps as well. So that's why I've had to have hysteroscopies. But the hysteroscopy is using a camera to look inside the womb. And I know many women have had traumatic experiences because I've had to have one awake. And some women are able to tolerate it. And I was just about able to tolerate it. But boy, I know it was painful. Now, sometimes it's quicker to be able to have them in outpatients, and they might give you something to just help relax you, or some numbing agent. So if it's offered to you, don't automatically think, oh, it's going to be awful. But for some women, it's just not able to tolerate it. And you can have them whilst you're sleeping, particularly if they want to do some procedure with it. So I've had it both. I've had it, under anesthesia, general anesthesia, and I've had it whilst awake. And you look inside to see, and this is for looking for fibroids that are inside the womb. And very rarely, if a fibroid looks abnormal, but that's rare. As I said, it's because they're not sure about the diagnosis. If it's very clear it's a fibroid, a biopsy is not needed. But it's only if there's some diagnostic confusion that a biopsy might be needed. Now, fibroid treatment will depend on symptoms, size, age, and what you want for your fertility goals. Now, you have to remember, some people need no treatment at all because they haven't got any symptoms. The size is small and it's not anywhere where it's going to be impacting any of their health. But for a lot of women, they start the treatment with so you can divide it, the medications or the medical treatment, to non-hormonal and hormonal. So non-hormonal includes anti-inflammatories, which can be really helpful with pain. And then tranexamic and mefenamic acid, many of you might have heard of this, which is to help with pain. So mefenamic acid is similar to ibuprofen. They're in the same family. They're anti-inflammatories, and it helps with pain. And tranexamic acid helps with reducing heavy bleeding. Now, hormonally, you have different hormonal options, and the hormonal contraceptives are a very good option for treatment. And I mentioned myself, because there's a lot of fear in our community, and also how we communicate hormonal options to patients can sometimes not be so clear, and it can make patients feel like they're being gaslit, particularly if they have fertility goals. So it's important to ask. Because if you're offering hormonal options, most of the time they hinder fertility. So if someone is trying to have a baby and you're offering them hormones, it can make them feel like, what are you talking about? But if you're not trying to conceive immediately, or it's something that you're planning for the future, hormonal treatments can be really helpful to shrink the fibroids and to control the bleeding symptoms. As I mentioned, I had the mini pill, but there's also the combined pill. There's the coil. The coil can be so good. Mirena coil. That's actually what I have right now for my to help control my polyps and thickening of my womb, which is a separate issue, but quite similar in terms of what the coil can do. And there's so many different options of hormonal treatment, and that's why if you've tried one and it hasn't worked, don't say, oh, I don't want hormones because I've tried one and it doesn't work. You may be able to try a different one, and there's so many different now they're even more natural estrogens, which are the same as our body produces. So they're they're pills with the estrogen the same as our body produces. And there's so many different progesterones that can help with other issues. So for example, if you have PCOS, they're anti-androgen progesterones that can help with your skin, your hair, the excess hair production and other things. So again, the choice of hormones is vast, and you need to speak to someone who understands it and can help work out what's best for you. It's not a one-size-fits-all approach. There's also the GnRHs, which kind of induce a medical menopause, because we know that in menopause, when you drop the levels of the estrogen, the fibroids can shrink in size. And then there's the new drug Raico. Raico is it's basically like a GnRH agonist, but it also has add back HRT to make those menopausal symptoms more manageable, and it can help with moderate to severe symptoms, because again, it's licensed to help with the symptoms of the fibroids, the heavy bleeding, and painful periods, and can help a little bit with shrinkage as well. Now, there are other kind of more involved options. So there's sort of the minimally invasive options. So like the urinary artery embolism, which cuts off the blood supply to the fibroids and they shrink. There's also the MR kind of focus ultrasound, which can destroy the fibroids. There's myolysis, which kind of burns the fibroid supply. Some of these are not great if you want future pregnancy. So it's really important to understand the future risks to your womb with some of these options. Again, endometrial ablation will completely destroy your womb lining and will cause infertility. So again, not really an option for someone who wants babies. Now, hysteroscopic removal. This is again something that can be done in an outpatient setting. It just takes out the fibroids via the vagina. So there's no cuts or incisions but the fibroid needs to be accessible. So it needs to really be one that's inside the womb cavity, and it can't be too big, and there's certain sort of so it's not suitable for everybody, but it's a good option that can potentially help and is less invasive than actual full-on surgery. Now, we would have heard about myomectomy, which is surgery to remove the fibroid and keeps the womb. And the whole process is to try and help preserve fertility. But there's also potential complications. It can cause scarring. So you really need to go into good hands for this. It's basically my top tip. And you also want to time it right so that it's done when you can quickly try and conceive, because often fibroids grow back, and you don't want to have too many surgeries because that can cause more complications with sticking and scarring of the womb lining. So it's almost like there's a certain number of these you can have before, even though it's to preserve fertility, it has to be timed right. It has to be in good hands. So someone who really knows what they're doing. And then finally, if you have completed your family, you can have, and you have really large fibroids, you can have a hysterectomy, but don't feel forced or gaslighted into having a hysterectomy if that's not what you want for your body. So please, it's about learning to advocate for yourself, and that just brings me to this, in treating fibroids, there's a lot of disparity in Black women. And this is, diagnostic delay, which I mentioned, dismissal of symptoms, systemic racism and medical gaslighting, pushing women to options they don't want, or not even listening to them when they say they have symptoms, not getting the diagnostics, not getting the right care, or seeing the right specialist who actually knows about fibroid management and is not giving, options that are, not appropriate. And then, of course, we're underrepresented in research and guidelines. So what is needed? We need culturally competent care, or culturally sensitive care that understands our background, where we're coming from, puts us at the core of it. It's personalized and tailored. We need early intervention and more fertility preserving options. So we are limited in what we've got. We've talked through some of the treatment options, but, we need more research, and we need to be trying to provide women with the best possible care. And we need inclusive education for both clinicians, and this is part of the work that we do with Heal for Black People, but also, with all the different organizations that I work with, and patients. And again, part of what we do, educating, we're doing this right now. And we need community informed. We need to bring women in to everything, to research, to policy, to education. Women need to be at the very core of it. So as I mentioned, in my case, managing fibroids isn't just about the physical symptoms, because it adds to the mental load and impacts quality of life. So they're really important pillars of general healthcare. So staying active, movement is important. But again, what you can do, sleeping, so important. You need to sleep well. Sleeping really impacts our hormones and all of it. And just it's so important for our general health. Now, being careful with alcohol and smoking, because these things can make everything worse. So moderate alcohol intake, be careful with stop smoking if you do, manage stress. I've talked about the mental load, the things that we can do to improve our stress, spending time in nature, movement, sleeping, all of these things. But it's also about setting boundaries. As Black women, we're often the person that everybody comes to. Let's learn to say no. It's okay. We can manage what we can manage. Let's not take on too much. These things are impacting our health, and it's not helping us to live our healthiest lives. Let's learn to delegate. Let's build communities where we can support each other. If you're able to afford it, get help. But if you can't, get help from your community, and let's learn to do some self-care. But again, don't put as a burden on yourself, because that's the thing. You start judging ourselves again. Oh, I can't self-care. No, it's okay. Some of us, we just be kind. Be kind to yourself. Let's try and eat the rainbow and eat as healthy, a broad colors of food, a healthy diet, balanced meals with proteins, whole grains, healthy fats, because it's going to help with our hormones and our health. And, so again, sorry, I don't know if you heard that, but because I was muted. It's a lot of things, but it's do what you can. Look after yourself, and that helps as well. So in summary, embrace your journey. You want personalized, culturally competent care. Prioritize self-care. Stay informed, continue learning and sharing. And you can go to your health provider informed and even challenge to provide advocacy for yourself. And then seek support from trusted, culturally competent healthcare providers. The Khan community is here, and together we can break barriers and uplift every woman on this journey. Thank you for listening. So here's how you can reach me. I'm on social media as at Dr. Showcares on YouTube, Instagram, Facebook. It's my website, drshowcares.com. And that's the numbers in which you can reach me. And yeah, thank you for listening.
Thank you so much, Dr. Itunu. That was so much information and so much very good information. And I really say thank you as well for sharing your own personal story about how fibroids have affected you and how you have managed them and being an advocate for yourself, because I think that's where a lot of the encouragement comes from when you talk on this really important issue. Thank you for people who have shared their information, and we've had some of their stories in the comments, and we do have questions. We do have questions for you. I just wanted to go something, hopefully an easy start. What is a biopsy?
So a biopsy is just taking a sample of whatever it is and sending it to the lab for them to have a look under the microscope and say what exactly it is from a pathological or whether it's something that is pathological or sort of, I'm using medical words now, sorry. A biopsy, you just take a sample of something and you look at it under the microscope and it tells you whether it's a normal cell or an abnormal cell.
Thank you. And we had questions about how can fibroids change over time. So imagine you've had an ultrasound and it showed one fibroid. If your symptoms change, would you recommend repeating that ultrasound? Or is there a case that actually you've just got the one? How should people think about that?
So yes, fibroids can change over time. First and foremost, they can grow bigger, and they do grow bigger. And that's why time matters, because a fibroid, in a year's time could be twice the size. It depends on, again, all these other factors that we mentioned, including your genetics, endocrine disruptors, and lots of different things. So, some people stay stable, like mine have been stable for some years, right? Some grow, and then you can have more. So, for example, you had one this year, maybe you have a scan next year, something has changed, and you now have five. God forbid, but I'm just saying, I'm using it as an example. If you've had one, you're more likely to have more. So if something has changed, go back and say something has changed, I need a new scan. Yeah, that's because it can always change.
Thank you. And then you mentioned, especially it seems like this is a bigger issue for those before the menopause. So after the menopause, what's happening to the fibroids? Are they shrinking? Do they disappear completely?
So it's unlikely that they disappear completely, but they shrink and they don't really become a problem, because really it's that cyclical change with the estrogen and the progesterone that you're having with your periods that caused all the pain, the bleeding and all of that. So a lot of the time they just shrink and they really just don't become a problem. Now, of course, if you are menopausal and you have HRT, some people worry, oh, is my fibroids going to become worse? So that's why if you have fibroids or endometriosis and you are having HRT treatment, we would usually give estrogen with progesterone, because the estrogen factor of, making it grow is prevented by the progesterone. And so, but you would have to go to a specialist to talk about your options, because there is a small chance they could grow, but we would try and support that or mitigate that with the progesterone. So you can still have HRT if you have menopause and you're fibroid and you're symptomatic for your menopause and you need HRT.
Thank you. I think that information will really help a lot of people here. I mean, you shared that you found the mini pill helpful for you. When things go wrong, or if you speak to a doctor and it doesn't seem like they're listening, what advice do you have in terms of going back to them or asking for a second opinion? Because that could be really scary. If you don't feel like you're being listened to, what can you do or what should you try and do?
You know, we actually have a resource, Dr. Showcase, that we're going to be bringing out by the end of this month, because it's Menstrual Health Month at the end of this month, to help women with questions that you can ask. So one of the questions that we've got on that leaflet is say something like, okay, doctor, you know, if you don't think it's this, what else could it be? I'm just wondering, because obviously I'm really worried it might be fibroids, but if you don't think it is this, what else can it be? And you can, you can see whether that question makes them reconsider. You can also say things like to the doctor, you know, is it worth, I mean, I know that obviously you said that is it worth potentially getting a scan just to be absolutely sure? You can go with a friend as well. And that sometimes makes people sit on their toes a bit more because you have that support in the room. And it's almost like it's two people, you have that strength. You can have spoken to one of the culturally competent supports that you have at Khan or other resources and say, you know, I spoke to another doctor and they wondered, you know, or they said, I should really ask for this. So sometimes having that extra support from another clinician that you've spoken to, or another nurse or someone, or a family friend who's, you know, just putting that in the room can often make people think. But, you know, if you're not getting through, don't give up. That is really important. Say, do you know what? You don't have to even say it in the room. You can say, can I be referred to a specialist because I'm really worried? If they say no, you can see a different clinician. Don't, you know, get a second opinion.
Okay, thank you.
Yeah.
I was still going to say, with the scans that you mentioned ultrasound scans and MRI scans. So, you know, is it worth just going straight to an MRI? Or if there's nothing on the ultrasound, is it still worth pushing for an MRI?
I don't, so the truth is that ultrasounds are really good for diagnosing fibroids. If there's nothing on the ultrasound, the chances that you have a fibroid or a fibroid that's clinically relevant is very, very low indeed. There really isn't much added benefit in getting an MRI of the pelvis at that stage. Now, of course, people worry about things like other conditions because there's, you know, we've talked about fibroids, but if you're having heavy pain and bleeding and there's no fibroids, you could have endometriosis. There's other options of things that could be there. It's not, you know, and you can have fibroids and endometriosis. Surprise, surprise. Multiple things can coexist. Now, MRIs, again, are not great for diagnosing endometriosis unless something has been seen on the ultrasound. And again, they would want to use just similarly, they use the MRI pretty much to plan surgery, and it's done in a specialist clinic. Now, there's other things that can be done. One of them is, and I often say this to patients, is that, of course, we know that laparoscopy is the gold standard for looking into the, you know, looking into the womb and looking for what's actually going on. The challenge is this, though. It is not a completely it's not a harm-free procedure, because with surgery, it can damage your bladder, it can damage your bowel, it can cause scarring, you know. So depending on the situation, right, it is often, if we can't see something on the scan, it's often best to try treatment as part of the diagnostic process. And the thing is, the way we communicate this sometimes can feel like gaslighting. Oh, they just said, go and use hormones. But actually, that's not what it is. It's not dismissive. It's saying, let's try hormonal treatment, because if it calms things down, then it suggests that there's something that we haven't seen on scan, rather than sending you to surgery, which can provide its own complications in and of itself and may not be necessary and might even impact your fertility in the future. Now, for some women, surgery is the only option, but because you try treatment, it didn't work, or lots of other things. But let's remember that hormonal treatment is part of the diagnostic process, but it's how we communicate it, and it has to be a shared care thing. And of course, if you are worried about fertility, that's a different conversation. And then we need to think about it differently. But if you're not worried about fertility immediately, you're not trying to have a baby right this moment, then it can often be a good option as part of the diagnostic process.
Thank you. I have a bit of a specific question, a bit of a specific case. So it's not so much just the answer to this, but how should one approach it? You see a doctor, they discuss something for you, they say hysterectomy. So I think this person said that they've got a womb size, and so the hysterectomy was recommended. So when you've been told something like that, what are the sort of questions that you should be asking, or where can you go for to get more information or to discuss that further? Sometimes you'll have a short appointment, or it doesn't feel long enough to ask all the questions that you want, or something, it's not until a bit later that you really start thinking things through, where you realize you've got so much more information that you're looking for.
I think in those sorts of circumstances, particularly if you want to preserve fertility, and this actually happened to a really good friend of mine who is a GP. Can you imagine? She was just told, oh, you need to have a hysterectomy, and she's in her 30s, early 30s. And the important thing is to, process that emotion, because it can sometimes feel so painful, right? How can this have been said to me? I wasn't even given the space. And it almost feels really overwhelming. So when you've taken a moment to process, think, where do I need to go next? And often the question is, you need to be referred to a specialist, to tertiary, to a center or a specialist that particularly specializes in fibroids. And if possible, you want to be looking for a culturally competent clinician. I mean, it's in this kind of situation where you research who you want to be referred to, ask around, because you want to go and see someone. So it may well be that it is inoperable. I mean, but you want to hear from someone who, if they're telling you that, it's 100% true, right? And they're telling you that with, all the concern and empathy that kind of situation occurs. But I would say it's quite rare to be at that stage. A lot of the time it's because people don't feel confident. And this is the thing I talk about, because some clinicians don't feel confident in their own knowledge, or they don't want to admit the limitations of their own ability.
So just to make sure that, sorry. I just wanted to be clear, with the hysterectomy, when you're taking out the womb, if you've already had children and the children that you want to have, then we're not so worried about fertility. It's less important. But if you've completed your family, then that might be more for an option for you. Would you agree that's accurate?
So if you have completed your family, please go ahead with your hysterectomy if you want to. No problem. I think the challenge is for those women who haven't, and then feel, what? You know what I mean? And so those are the women who need to go and see, who need to make sure that they're getting their information from someone who has a subspecialty interest in fibroids and understands culturally competent care.
Thank you. And just fibroids cancer, can fibroids turn into cancer? Is that something we need to be worried about?
So if it's a fibroid, it doesn't turn into cancer. And I think we need to be clear about that. It's only if it was the wrong diagnosis. And like I said, I've had polyps. So I've had fibroids, I have fibroids, and I've had polyps. Polyps are growth on the womb lining. Those can become cancerous, particularly for women who have polycystic ovarian syndrome. It becomes a higher risk because you're more likely to get endometrial thickening, and then you can get polyps. So again, we need to be clear on the right diagnosis. Fibroids, polyps, they're different things. Polyps can, over time, become cancerous. So it's always important to have a biopsy on a polyp. But fibroids, if it's the right diagnosis, they don't become cancerous.
You've been speaking about different treatment options. You've mentioned hormones a few times. And so, sometimes people hear hormones are bad for the body long term. Or can you just explain a little bit more about the hormones and using them as a safe long-term option?
So when I talk about hormones, right, it's usually the hormonal contraceptives that I'm talking about. Of course, we've got the newer agents, so the GnRH agonists. Well, they're not that new, but we've got Raico as well, which is this treatment that induces a medical menopause, and then you add back the hormones. But let's start with the contraceptive hormones. So roughly speaking, we have estrogen and progesterone combined options, and that comes in the pill, the patch, the coil, the ring, sorry, the pill, the patch, the ring. And then we have progesterone only options, which include the progesterone only pill. And now we have really 3 types of progesterone only pills now. So it's increasing. It used to be 2. So we've got norethisterone, Noriday, we've got desogestrel, and now we have drospirenone, which is an anti-androgen progesterone. So again, the options are increasing of hormones, and we match them to what your needs are. Again, with the combined options, there are so many different. So usually you have one type of estrogen, well, 2. There's the ethinyl estradiol, which is the synthetic estrogen, and then we now have the newer pills with the estradiol, which is the same body identical estrogen, and then we have so many different progesterones that combine with it. So again, we can try and match it to your needs. So those are the contraceptive options, and with the progesterone only option, we've got the pill. As I mentioned, we've got the coil, which can be so fantastic, honestly. But I know it doesn't work for everyone, so I'm not saying that, but it's often worth a try. We've got the injection for the, and then we've got the implant as well. And
Dr.
then, as I
Itunu,
said,
so
we've
I'm
got
just
the
smiling. I'm just smiling as all of these names roll off your tongue and the different options which are available to women. And it just shows how much of an expert that you are. So we really appreciate having you here today. I think just one thing to highlight that what can be difficult is when the same thing doesn't work for everyone.
exactly.
And it really shows with, your story, with other stories, the ones people have shared, that sometimes it will be different things or combinations of different things, which will be the right treatment for the individual. And I think sometimes you can also become quite tired or become fatigued when you're going through that process and having to keep trying and then it doesn't work and the disappointment of that. But hopefully, as you even mentioned, all of these different options that with time and by talk to experts like you, finding that right person to help you along the journey, that you'll be able to find something that does work. I just want to
Absolutely.
quickly as well get your point of view in terms of what you're aware of. Why is this happening in the Black community? I know there's been some research very recently about what's going into relaxer and the chemicals that sometimes people use in their hair. What are you kind of hearing about that sort of research?
So, I mean, there's been an association found. I think there still needs to be more research to fully understand that. I think the broader issue is that there's so many things that are endocrine disruptors that impact our community disproportionately. And so why we have fibroids more, it's probably a mixture of genetics and environment. And that could include, the environment, the disruptors, including potentially relaxers. We talked about vitamin D deficiency. We talked about, stress, right? The disproportionate stress that Black women are often under. So there's so many different factors. We need to unpack that. We need more research. And there's been a call for more research at the APPG that I was at on Wednesday. That was one of the major things that was talked about because we just don't know enough.
Which is sad, but we optimistically look towards the future where we do have more answers for these issues. I do just want to quickly raise as well, fibroids, they can grow back. For people who are thinking about fertility, is there any kind of thought process when it's trying to time operations? You know, they might advise you to remove fibroids and then trying to have a baby, then know that they can grow back again.
So me,
What
I try
advice
and
can
have
you give around
honest
that?
conversations with people,
Okay.
you know. If, you know, we have to be, if having babies is a priority for you, obviously you have to think about being ready, you know, and I would never encourage a woman to do something she's not ready for. But we have to be mindful of the issues that impact our community. So fibroids is one of them, but it's one of a number of issues that impact our fertility. So our fertility in our community, in our Black community, peaks slightly earlier than in the Caucasian community. We have to be aware of that with timing. And of course, with fibroids, it gets worse as we get older, doesn't it? So again, with the removal of fibroids, timing is everything because it's almost like as soon as that surgery is done, you really want to start thinking about trying almost once you're recovered because of the chances of it growing back. And then, as I mentioned, having multiple surgeries increases your risks of scarring. And I've seen patients, they've had so many myomectomies, everything is scarred, nothing can stick. And you don't want that situation. And so we obviously don't want to scare women. And this is why it can be so, you know, we have to talk empathetically because we have to see these women as we would talk to a member of our own family, right? Because we don't want to scare women, but we want to give them the accurate information so they can make the right choices for themselves and their families, you know? And so,
This is
yeah.
sorry.
No. So all I
I
was saying,
just one last question. Um, so in case actually you think that your periods are normal, they don't cause that much pain, is fibroid something that people should be worried about or trying to work out whether they've got fibroids or not? Or can you presume you don't have an issue with fibroids if you don't have much in the way of symptoms?
if you're asymptomatic and you're not dealing with infertility, you don't need to worry about fibroids. You probably have them. They're probably small and they're not causing any issues. You know, it's not something that you need to be
Okay.
like, you know, I need to find out if I have fibroids. No. It's if you're having an issue that you need to now find out why. And then, of course, fibroids can be one of them.
Wow. Wow. That has been a lot. Thank you so much for your wonderful presentation. So many people comments have just said how grateful they are for you going through the presentation and giving all this information in a way that we can understand. It's information that needs to be shared with the younger generation, with the girls, with women, because it's such a shame when it's decades later when people are being diagnosed with things in their 30s, 40s, beyond, when the symptoms and the pain and all that turmoil you mentioned started years earlier. So just want to say once again, Dr. Itunu, thank you so much. You've shared your contact details, and I'm sure there'll be more questions directed towards you. I want to now hand over to Percy, who's going to be closing for us today. But thank you, everyone, for the questions. Thank you so much for engaging with the presentation. And hopefully, you've taken away something meaningful that you'll be able to share with people around you.
Uh, Thank you so much, Dr. Lizzie, and thanks so much, Dr. Itunu. I mean, that was a very brilliant session. Thanks for running us through that. I mean, the answers to the questions, the facilitation, I just thought it was brilliant. So even for myself, lots of things to take away. And really, all we can say is thank you. So thanks for coming on the call and then sharing all that knowledge with us, really. So really, everyone, I mean, brilliant. Thanks to you as well for joining the call. Just as we wrap up, a couple things to run through on our end. So I know Dr. Itunu did mention the all-party parliamentary group meeting that happened on Wednesday. So off the back of that, really, we see it's been clear really that there is an issue when it comes to fibroids, and there is a clear gap, especially in the research around it. So we've launched a call for evidence, and that will be running up until mid-June. So please do scan the QR code. And if you want to hear from you as well, get to know your experience and your journey and see how we can use that to properly influence policy and practice. So please do make sure if you know anyone around has been affected by fibroids, and working on getting responses from across the country, really. So it would be really important to get those responses from yourselves, really. Just share your journey with us, really, and we're collecting that to be able to make clear recommendations to the system of where improvements needs to be made. So please do engage with that. It will be up on our social media channels as well. So please do endeavor to share that with your contacts. As always, for next week, Saturday, there will be another brilliant session. It will be on stroke awareness, and we would have a very familiar face, Dr. Ayo, join us on the call. So please do endeavor to tune in into that session, same time, same place as well. And we've got lots of convening events where we tend to bring different sections of our community together, celebrating various things from what is working well and also celebrating key people within our community. So on the 22nd of May at the University of Greater Manchester, it will be our Africa Day. So please do endeavor to register and plan to attend. It's going to be a brilliant event. There's a huge focus on business, and please do endeavor to register to attend. Really lots of useful information to take away from that. So look forward to seeing as many of you as possible. Another event which is really big outdoor would be the Windrush event. That will be on the 21st of June next month. So please do endeavor to save that date in your diary. It will be at Alexander Park in Manchester. Lots of entertainment, lots of fun will be happening on that day. So please do endeavor to keep it a date with us. And the other thing as well, which we've got coming up in July, is the Black Healthcare Awards. I mean, last year's inaugural award was brilliant, and this year it will be at the same venue and even better as well, really. So please do endeavor to register for that. We look forward to seeing as many of you as possible. Do share these dates with your contacts as well, really. We want to make sure we're collectively pulling our communities together, really, and we're creating that space to be able to recognize the brilliant work of healthcare professionals like the amazing Dr. Itunu and Dr. Lizzie, who are on the call today, really sharing very useful information with us today. Yes, the other thing to mention as well is our Green and Art Wellbeing Service. So it's got two hubs where we're situated in Greater Manchester, one in Bolton and another one in Stockport. So lots of creative workshops takes place in those settings. So please, if you know anyone who is within that area, who is resident in that place, that this service will be useful to them, do endeavor to get them to refer themselves into the service. Really, it's a very brilliant and engaging service. I was there 2 weeks ago myself, and it's a really, really good service. So yeah, as always in Cannes, we've got lots of volunteer opportunities. So please, whether you're a healthcare professional or even your community member, really lots of opportunities to give back to our community and then to support our work within the community, either being from the professional side of things or even just lending your voice to the cause, really. We want as many people as possible to maybe engage in this work, really, either it's through service focus work or even through policy, the health screening, and all those health checks that we do in the community. So please do endeavor to show your interest and then to support this work, really. So I think that's all for us. I mean, just to say thank you so much for joining us today, and we hope to see you all next week again. In the meantime, do have a lovely rest of the week. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Programme, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions, spread the word in our community.